Okay, well, welcome everybody. Folks will be coming in as we started. But welcome, my name's Gary Daffin. I'm with the Multicultural AIDS Coalition, one of the convening groups of United We Rise. And for those of you who don't know us, I think most people do, United Rise is a Black-led intersectional collaborative. And what we do is try to reimagine a pathway to the end of the HIV epidemic, while at the same time uplifting the health of all Black people. Our work is grounded in dismantling racism that permeates Black life. And we have really gathered to engage communities in answering the question that we came up with when we first started, which is, what would the response to HIV look like if it were led by Black people? So that has been kind of our guiding question for the past 5 years. We were started back in 2019, aging myself, by a group, both MAC and the Black Women's HIV/AIDS Network and the National Black Gay Men's Advocacy Coalition, pulled together groups from people from all around the country to really think about that question. So what would it look like if Black people were designing the way to end HIV? So we have a great conversation today with researchers, Black researchers, a great group that's going to talk about Black folks leading the effort to find ways to end the HIV epidemic, and also talk a little bit about what the challenges are today in the current environment. Before we get started, we wanted to just take a quick look at a project that we started a couple of years ago, which is the Black Researchers Directory. And I think we have that up. Let's see. Yeah, so we're just going to do a quick overview. Next slide, just to give you a sense of. So this directory was created really as a way to offer multiple pathways for connection and collaboration. We wanted to have both Black researchers and people in the community at community-based organizations and people who participate in research all have ways to connect and work with each other. So we wanted Black researchers to register. We wanted Black-led community organizations to be able to find researchers that align with the work that they're doing and their interest and needs so they can be a part of designing the research. And we wanted to make sure that we had researchers with varying backgrounds from varying disciplines and experience that can achieve the visibility that can be challenging, that can challenge um, sort of the traditional ways that research has happened and have it be more organic and think about what are the best ways to get people to both be a part of thinking about what questions we need to answer and how we need to answer those questions. Next slide. So in the profiles, and we'll show you the link in a minute. So each of the profiles just has some information about the different people that are on, the researchers and the community folks, the names, pronouns, the title, the organizations they work in, contact info, social media handles if people want to put that up, a picture ideally, gender, and then what research areas folks work in and what type of research they're doing. Next slide. So I don't know if I can click on this or I think you have to, if people want to take a look to everyblackbody.org, and then you can click to our research database. Or as someone who from the community, we would love for you to join us and be a part of that so that people can find you and um, really engage folks and get people's expertise from across the spectrum. So with that said, let's have Daniel Downer lead us in. What we try to do is a sort of grounding exercise to start each of these, particularly given the kind of crazy times that we have. So Daniel, want to get us going?
Yeah, absolutely. So, good day, everyone. Welcome. As Gary said, before we have our couch conversations, we always love to just do an exercise to ground us. And so, I want to lead us in that, if that's okay, especially the importance of what we're doing, sharing space and gathering today, because we're gathering at a time when Black communities are on the front line. So, activists, researchers, every person you can list fighting for not only health, but for justice and liberation. And we know that many programs and networks, they're under threat. Many researchers and communities are also being sidelined, but we're still here and we are rooted, we are resilient, and we are radiant. So, for the next few minutes, I want to invite us to connect not only with our presence, but to honor our communities and to affirm our power. So, if you want, you can sit tall in your chair, you can plant your feet firmly on the ground, you can rest your hands on your heart or anywhere that's comfortable. Just make sure you feel the weight of your body being supported, but also that you're feeling all of the strength of those who have come before you, who've come before us. So, thinking about the ancestors, community leaders, even researchers, and the list goes on, flowing into us and through us, right? And thinking about just how our bodies are bodies of resilience and knowledge and care, and just taking a moment to root ourselves fully within this space, knowing that our presence here, it really matters. And I want to invite you to repeat after me. I'll say a line, and if you want to whisper it, you can. You can also say it in your mind if you want, but most importantly, I invite you to feel it in your body and in your spirit. I am seen. I am powerful. I am here for my community. I resist erasure. I carry knowledge, joy, and liberation. And I'll do it again so we can really let it set in. I am seen. I am powerful. I am here for my community. I resist erasure. I carry knowledge, joy, and liberation. I also invite you, if you want, to type into the chat um, what captures the energy that you're bringing today. It could be courage, it could be hope, it could be resistance, clarity, or joy. And really just take a final moment to feel these affirmations, not only in your body, but also within your mind and within your spirit. Being here, rooted in the amazing work that we do, connected to the amazing communities we're connected to, but also carrying that power to resist and heal and transform. And if you've closed your eyes, I invite you to open your eyes. If you want to stretch, I invite you to stretch. But also, I want us to bring this grounded, radiant energy throughout our time together with this conversation. So, thank you all so much.
Thank you, Daniel. So the other thing that we try to do with at each couch conversation is to have a quick update on from an organization that's working at the national level to figure out what we should be doing in this, as Daniel said, very challenging times. So we have Max Boykin is going to give us a quick update. Max, I know you're traveling, but if you want to tell us a little bit about yourself and what's happening out there.
Hey y'all, hope y'all can hear me all right. I am in the TSA line, and one of the things that is impacting all of this with this government shutdown is travel at the airports. But my name is Max Boykin. I am a manager of the state HIV funding campaign. I use he, him pronouns, and I am leaving Atlanta headed to DC to have an important conversation on PrEP. But with that, we are dealing with a government shutdown now, day 28. The second longest government shutdown that we have ever had in this country's history. We have people that are going without paychecks. And one of the biggest things that we're also seeing outside of just government employees being impacted by this is also different benefits. And one of those ones that will start going away on November 1st is SNAP benefits. One of the things that is important today is the SNAP Day of Action. And I can share a little bit later uh, once I get through this TSA line to make sure that people are able to make sure that they are able to call their legislators and make sure that they understand the importance of this, and also make sure understand why this is happening. And one of the reasons that this is happening is Democrats are trying to make sure that people are able to continue to have access to healthcare, especially everyone that signed up for the ACA during 2021, 2022, and other years to make sure that their tax premiums don't go skyrocket through the roof. Certain states that you can already start to see that. With this, one of the things that we're able to continue to make sure that we want to make is continue to put pressure on our legislators, understand that we want fully funded healthcare services along with a fully funded government. That's one of the things that we're pushing to. And we don't know exactly when this timeline will shift. We are going to potentially like as we get into November next week, of looking like potentially what happens with the government shutdown there. But outside of that, we're also going to see like if one of the sides continues to move one way or the other around how this is moving. I'm going to have to go. I'm about to go through the TSA line, but thank y'all, and I will check back in y'all soon.
Thanks, Max. So yeah, lots happening. Hopefully people aren't being too impacted by the shutdown, which there's some sign that it might end soon, but we don't know. But so for today, we're going to have a conversation about HIV prevention and treatment networks that are engaged in research. And we're going to have a conversation that is led by United We Rise's own Christopher Ortiz. Christopher, you want to take us away and introduce our panelists?
Certainly. Let me see. Video off. You would think that 20 years into Zoom meetings that wouldn't that I wouldn't have to talk to myself to make sure video is off and sound is on, but that's what we do. Good afternoon, everyone. My name is Christopher Hux Ortiz. I'm the CEO and principal consultant of Equitable Solutions, located here on the left coast in the Seattle area, and a member of the management team, or not management team, but leadership team for United We Rise. Today, I am really, really pleased to welcome some of my dearest friends and colleagues. These are folks that I get to work with all the time and have the utmost respect for. We'll be going through and meeting with Dr. Danielle Campbell, Dr. Darren Whitfield, and also Dr. Ulysses Burley. Between the three of them, we'll be able to have some conversation about the NIH-funded networks that fund HIV-related clinical trials, and there are a number of them. I'll list a few of them, and then we'll jump into intros, and then we'll go from there. There are a couple that are really important. We'll be talking about the HIV Vaccine Trials Network, or the HVTN. We'll be talking about the HIV Prevention Trials Network, or the HPTN. We'll be talking about what's called the AIDS Clinical Trial Group, or ACTG. We'll reference what's called IMPACT, or the IMPACT network deals with vertical transmission, mother-to-child transmission, not only in the United States, but around the planet. And then we'll also touch on a couple of networks that had been funded, but no longer exist. They have had funding rescinded, and that will include the Adolescents Trials Network and the Rectal Microbicides Trials Network. So very quickly, we'll start with you, Dr. Campbell, if you can just briefly introduce yourself. Anything more that you'd like to add on top of what I've shared with regard to you?
No, nothing else to share. Thank you so much, other than thank you to the organizers for this amazing opportunity to stand before you virtually, albeit alongside such Black excellence. I'm humbled for the invitation and excited to hear how the conversation unfolds.
Great. Awesome. And Dr. Burley, UB, if you'll go next, please.
I am founder of UB The Cure, which is a Chicago-based organization that operates at the intersection of faith, health, and human rights. I am a principal investigator with the HIV Vaccine Trial Network, where I lead their faith initiative. I am an immunologist by primary training, but I'm also a minister, and much of the work that I do is at the intersection of faith and HIV. So my comments today will not only be about the HIV Vaccine Trials Network, but also about associated faith-based initiatives that are at the intersection of research and community engagement that are also being impacted by the current situation in our country.
Wonderful, wonderful. Thank you for that. And then lastly, but not last, Dr. Darren Whitfield.
Good afternoon, everyone. Darren Whitfield, I'm an associate professor at the University of Maryland, Baltimore School of Social Work. And I am recently elected the chair of the Black Caucus for the HIV Prevention Trial Network. I've also been associated with several concluding and ongoing HIV Prevention Trial Network studies, including 073 and currently 096, which I'll touch more about in my remarks. And I'm happy to be here this afternoon.
Great. Awesome, awesome. Thank you all three. So what we're going to do is go through some conversation and some panel questions. We'll start with that, and then later on, as folks have questions for you all, we'll save those until the very end. If you have questions that you place in the chat, feel free to do that so that way we'll highlight some questions that come from the audience and would like to make this as interactive as possible. So with that being said, my first question for each one of you would be asking for a brief overview about the HIV prevention and treatment networks, including some of what their purpose is and how they work with the NIH. Just a general brief. Dr. Whitfield?
Get started, or Dr. Whitfield?
We'll start with Dr.
Whitfield, the
Whitfield.
consensus. Yeah, you take it.
Sure. Sorry, I saw you were unmuting to Ulysses, so I wanted to give you an opportunity. So I'll just very briefly. So the HIV Prevention Trial Network, or the HPTN, is one of the DAIDs, of the Division of HIV/AIDS Research, funded funded centers whose primary mission is to work on both clinical trials and implementation science, research related to the prevention of HIV/AIDS, both domestically and internationally. It collaborates with other networks. So there have been some dually funded HIV prevention, HIV vaccine trial network studies that have come about. This network has been responsible for some of the most recent advances in the field of HIV prevention. So the network was part of studies that prove U equals U. So HPTN study 052, the injectable cabotegravir, so HVTN 083, and then subsequent follow-up studies, and the list goes on and on. So there's been numerous breakthroughs that have been through this network that funds both domestic and international HIV prevention efforts. And I will stop there.
Great. Ulysses, what about you?
Yeah, so one of the other organizations that is funded largely by the Division of AIDS at the National Institutes of Allergy and Infectious Disease is the HIV Vaccine Trials Network, or HVTN, which is the largest publicly funded clinical trials program made up of a collaboration of international scientists and clinical trial sites and community representatives and other networks like the HPTN in partnership with governments to find an effective HIV vaccine. That is essentially what the HPTN does. There was a stint where the HPTN was responsible for monitoring and evaluating COVID-19 vaccines, and I'll talk a bit about that later.
Okay, awesome. And Danielle, did you have anything to add?
Sure. So, as someone who has worked very extensively within the confines of the now advancing clinical therapeutics globally, previously the AIDS Clinical Trials Group, I've worked extensively at all levels of the network's operation functionality. So, in contrast to the prevention networks, the ACTG, as it's uh, mnemonically known, is the Global Clinical Trials Networks that conducts research to improve the management of HIV and its comorbidities. That includes developing a cure for HIV, developing innovative treatment strategies for tuberculosis, hepatitis B, and other emerging infectious diseases, starting all the way back at the height of the epidemic in 1987. Much to what's been described previously, it is comprised of thousands of global investigators who pursue relentlessly therapeutic interventions and cure for HIV and other comorbid conditions, recently pivoting to also incorporate aspects of implementation science, behavioral and social behavioral and social research, in addition to its robust community presence all throughout the network as well, which uplifts and bolsters the success of the network's ability to conduct these global trials. I'll stop there.
Okay. Oh, wonderful, wonderful. Thank you all for that. So when we think about these different networks, what I hear is not just what we like to call bench science, but also implementation science, also including a variety of combining intervention strategies into what we call integrated strategies. Um, that being said, and Darren spoke a little bit to some of the successes of some of the networks, but what would be some products or things that folks would be aware of that might be outcomes from any of these networks?
So Derek mentioned some of the HIV products. I'll mention the mRNA-based vaccines for COVID-19.
Mm-hmm.
During the COVID-19 pandemic, the HVTN and its partners developed a parallel network, the COVID-19 Prevention Network, which was expressly tasked by the government to monitor and evaluate government-sponsored vaccines, which included the mRNA products, because we specialized in clinical trials up until that date. And so many of the vaccines that we all benefited from and still continue to benefit from were a direct result of work done by the HIV Vaccine Trials Network in partnership with HPTN and others.
Awesome. What about you, Danielle?
So, speaking from an ACTG perspective, I spoke topically about the robust engagement of communities at all levels of the ACTG network, including representation on all of its scientific protocols throughout the network. So I'll speak again and say that this is a paragonic model for community engagement that's being leveraged, particularly in times of challenge, as we know that there's a deprioritization of community involvement, not only throughout the division of AIDS-funded networks, but when you look proximally at the Martin Delaney Cure Collaboratory networks, community is sort of left wandering in the wind or muted as a result of executive orders, and how we can show up and continue to represent our interests and have our voices seen and heard within these networks. Dr. Burley, you want to? Okay, thanks. So just to that point, I think, one of the biggest outcomes or successes of the ACTG is not only the robustness of the community presence within that network, but if you all have ever heard about the Reprieve study, and it's a super important study when you consider the deleterious effects of major adverse cardiovascular events and measurements of inflammation and asymptomatic heart muscle damage in people living with HIV. More recently, this Reprieve study, or it's the randomized trial to prevent vascular events in HIV was the first ever large-scale trial to test a primary prevention strategy to reduce the increased risk of cardiovascular disease in people with HIV. And when you think about HIV disease and the low level of inflammation that persists and the pursuant health outcomes, this study was a landmark study that led to changes in national and global guidelines around prescribing statins to people living with HIV to thwart some of these adverse cardiovascular events. So I think that's just the tip of the iceberg of some of the amazing science that's coming out of the network. And more specifically, this was one of the few studies that I'm proud to say robustly represented, enrolled, and engaged women across the gender spectrum. So kudos to the network for those scientific advances and policy changes that affect treatment and prevention thereafter.
Awesome. Thank you for that. Thank you for that, Danielle. Before we get to Dr. Darren, I have a quick question for you, Dr. Darren. You'll be the first person to step into this space. Because you made a reference to the HPTN Black Caucus, and I understand that the caucus has a particular work plan, and the way that that shows up within the network really speaks to a lot of the things that we'll be discussing today. So, and this will be for each of you. What have been some of the challenges, right? We think about stigma and, and all of the reasons why African Americans and Blacks, Blacks and even other populations do not necessarily participate in clinical trials at the same rate as other populations for a variety of different reasons. We talk a lot about stigma in these spaces, especially with regard to HIV trials. That being said, what would you note would be some of the challenges that you might have seen with regard to getting engaging Black folk into the networks, into some of the trials that are being planned and implemented?
Yeah, so I'll take that question here in a second. I did mention some of the sort of landmark studies, but I'm going to answer partially your second question, but also just I wanted to highlight a few other things in terms of the contributions of the network outside of products that we know have been very successful. I will note that 083, which is the injectable cabotegravir study, also was the first time the network engaged in a system in which we set targets for populations. And that was actually a product of the advice with the Black Caucus, which I'll speak to in a second. But it was one of the first network studies to in fact, set targets within a protocol that said we will recruit X number of trans women, we will recruit X number of Black MSM, and that was the first time that that had been done at any HIV prevention trial network study. A few other things in terms of implementation science, 073, which was technically a demonstration study, was really thinking about on the heels of the international trials around PrEP, the initial studies. It was in response to the fact that those studies had under-enrolled Black MSM internationally, and so it was not necessarily deemed that there was enough data suggest the efficacy of that. And so 073 was actually in response to that to follow up to prove the acceptability of PrEP in Black MSM, Black men who have sex with men in the United States. And so I highlight that. And then the most recent study that's currently being funded right now is an integrated strategy study, which is set in the southern United States to really think about how do we engage Black sexual and gender minority men in HIV prevention and care efforts, thinking about the holistic nature of HIV prevention and care. So considering things such as the geopolitical space, things such as how we support men, things about healthcare and healthcare facilities and settings. And so thinking about all of these components in an integrated way to say, like, these are all the aspects that impact the ability for Black sexual and gender minority men to engage in HIV prevention and care. And these are the intersections that need to be addressed, and think about how we target to improve outcomes for these communities. So I just highlight those because I think when people think of the HIV Prevention Trial Network, we also always think of the splashy drug and biomedical interventions, but we don't think as much as in terms of the implementation science efforts that also have been a result of the HIV Prevention Trial Network. So, and then I'm going to pivot here to say that, I mentioned 096 and also 083 where targets were set. And I think there's been some real attention in large part through the HIV, the HPTN Black Caucus to really elevate the need for how we engage in communities with Black folks to ensure their representation in these network studies. And so what you have is a study 096, which is really a result of all of this work that has been done over the years on the backs of other studies to say, like, we need to be intentional about how we address HIV in the South with Black folks. And we need a response that is robust and isn't just medication, because that doesn't work, right? We need to be engaged with communities. And it's been through these collaborations and conversations with the Black Caucus to think about how do we do a better job. And part of that you've seen is much more intentional community engagement, not only after a protocol is written, but as a protocol is written. So there's been concerted efforts in 096 and with the Black Caucus to engage in communities up front to say, what does a protocol that really impacts HIV in Black communities look like? How do we need to show up? How does that look different than any network study that's been done before? And the result is this package of interventions that is much more and very different than anything the network has done, right? Because it's much more intentionally based on community and based on that feedback, and is really rooted in the tools that are needed. And so what you do not see is this is not a randomized clinical trial, right? This is a real intention to think about implementation science and think about what are the tools that already exist, but how do we put them in practice in these communities to get the results we need? And I'll stop there for my colleagues.
Wonderful. You made some references to ensuring representation of Black folk, which I think definitely goes back to some of the challenges about engaging Black people in some of these network studies. I know that they're not just happening within the HIV Prevention Trials Network. So, so Danielle, how is that looking, or how does that show up in? And I'm sorry, I keep wanting to call it ACTG.
You still can. It is still the ACTG, just the moniker changed is all. And
Okay.
so it's exciting to hear this conversation, as sort of grim as it can be at times, right? We know that Black people are disproportionately affected by HIV, but by contrast, are not equitably represented in network research studies across the Division of AIDS funded research networks and other proximally funded networks. And it brings to my mind a conversation that PrEP and Black America has been having for quite some time. So PrEP and Black America started on a journey the year before last as a pre-conference to the NMAC National Biomedical HIV Prevention Summit to unpack this very same dynamic. Why is it that we as Black people bear so much of the burden of HIV, but we don't get to, one, participate in these HIV research studies that are funded with taxpayer dollars, and two, why don't we get to benefit from some of the scientific advances that are yielded from taxpayer dollars that we know ultimately will shape the future of not only HIV prevention, but treatment? And so we convened a pre-conference to the National Biomedical HIV Prevention Summit in 2024 to ask Black people this very question. What is it that is needed to reshape our relationship with research? And through these conversations, we had to unpack very, very traumatizing, traumatic experiences in Black existence, both lived and passed through our ancestors around why it is that we don't not only participate in research, but engage in healthcare, and a myriad of reasons as to what lies beneath in regards to our relationship with research came to the surface, right? It's the divestment of research education in Black communities and organizations that we seek services which then in turns minimizes our ability to trust the research process. And you can point to any number of historical traumas that have been perpetuated against the Black body to serve as the basis as to why we don't participate in these research studies. But in addition to that, we have to turn focused 180 degrees and look at how these systems are set up. They are not set up, led by, governed in consideration of the Black lived experience. They are just not. So Prepping Black America engaged the community. There were more than 350 of us in a hotel conference center in Seattle. I think we were all of the color at that conference. And we built the bones of this national Black focused HIV prevention research agenda, the first of its kind. And we took that on the road to the Southern US. We went all the way down from Florida all the way across to the West Coast to my very own Los Angeles, California, to ask Black people, what is it? What's missing? What do we need to do different? How do we reposition our relationship with research? And from those conversations of more than 1,000 Black people on the ground in these cities, the National Black HIV Prevention Research Agenda was born. And so in it, it's a document, it's living, it's transformative, and it outlines what we feel as Black people from stakeholder to consumer, what needs to be done differently for Black people to meaningfully engage in research networks. Spoiler alert, that's also the focus of my dissertation, applying an intersectional approach using a mixed method study to look at that very same research question in cisgender women who bear the global brunt of the HIV burden.
Awesome. Thank you. Thank you. Ulysses, UB, how is that looking in the HVTN?
Yeah, so I echo everything that Darren and Danielle have lifted up. I think in the HPTN in particular, we are seeing the disenfranchisement of the development of the next generation of young Black researchers. And so one of the consequences of the federal cuts is that programs like RAMP, which is the Research and Mentorship Program that the HVTN sponsored, it was a program specifically for mentorship and funding of African American physician researchers in training. And so they would have the opportunity to learn from um, um, other Black researchers within the network and our associated networks, as well as own their own projects, see those projects to their outcomes, and then receive funding for their future training as they continue to matriculate through their education. If you go to the RAMP website right now, it will say in big letters, RAMP is suspended until further notice. And again, that's a consequence of what's happening in our country right now. And it continues to affect the pipeline of young Black clinicians, researchers, community um, 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 advisors from being a part of the solution to our own problems, right? And you know, it's consequences that won't just be undone, 3 years from now, if you will. These cuts will have long-term effects, particularly for people who look like us. As Danielle eloquently stated, we bear the brunt of the HIV epidemic nationally and globally. We should have a stronger representation in terms of the response, and we are feeling the consequences of the cuts in that way. For the work that I lead with the HPTN, outside of the scientific work, I also lead the HVTN's Faith Initiative, which really was developed to work at that intersection of implementation science and wet bench science, where some of the most trusted community voices in faith were equipped and trained to be able to talk about HIV science, particularly HIV vaccine science, and then share that information with their communities. That cohort were all but one of our faith ambassadors are people of African descent. And as a result, again, of the cuts, our faith initiative was suspended back in April. And so people who otherwise don't have access to researchers and physicians and clinicians, but they have access to the person that goes to their church with them on Sunday, or the person that they go to synagogue with or mosque with. Um, People who look like us, who otherwise could benefit from the research that's being done by our collective networks, um, don't have access to that information that they need because of the cuts that are happening that disproportionately impact Black people and community, but also Black people within our networks.
And before we, sorry, Christopher, before we move to the next
Yes.
segment, I want to say something that is across all of these networks. We
Definitely.
talk about the burden of HIV in Black communities, and not only domestically, but globally. And one of the things I can't help but notice is that there has not been one Gates-funded network that has been chaired or led by a Black person. We have not had one. These networks have been around for funding, what, 20 years or so?
More than that, since
More than
1987 for
Yeah,
the
this is
ACTG.
yeah,
this
depending
is
on the
25
network.
for the HPTN. Yeah, this is
Mhm.
year
Yeah.
25. Yeah.
So, I think that is worth also noting that we talk about this pipeline, but it has to be said that there has not been leadership at the top that has been a Black person.
And thank you for making that statement.
Mhm.
It sort of, reinforces the chilly reality that we all contend with when you talk about not only developing the pipeline of future research leaders. And I also note that the HPTN Scholars Program, where is it? Was there a cycle this year?
It is happening.
It's happening
It is happening. It is,
for 26?
yes, there will be, there was
Okay.
something released recently. It is happening, but it was paused,
I
you're
do.
correct.
Okay, I was gonna say, I know good and well, I looked at that website and it was very clean about what the program was for and what it was not. But I think, sort of bringing us back to center, what you said was spot on in terms of why is there not equitable representation of Black people, not only as trial participants, but also in the leadership at the top to truly steer and incorporate a vision of these that include Black people. So thank you for that.
Mhm. So then, when we think about, some of the inclusion, not just of Black people as participants in trials, but several of you spoke to some of these pipeline opportunities for training and development of researchers at every level, including medical doctors, um, clinical psychologists, sociologists, et cetera. What would you say happens, right? Just within the when networks receive a loss of funding, right? Where this is all very pertinent to the political and economic realities that we're looking at right now. That um, that a lot of things, services, clinical trials, et cetera, that had previously been funded, are seeing some lack of federal support in the same way that a lot of other spaces are, including, HIV services. Um, so when these things happen, like we're experiencing right now, every single day, um, whose voices, what happens to the voices of folks like community people, the folks at the church, the folks at the barber shop, the folks just raising and taking care of their families and really kind of being stakeholders in their communities and in their networks. Um, uh, and then what's the impact of that? What does that mean for Black communities?
So I'm gonna use, so let me be clear. I'm gonna answer this question as Dr. Darren Whitfield from the University of Maryland School of Social Work, not as the chair of the Black Caucus. So I want to make that very clear because I know we recording this bad boy. So let me be clear up front. What you will see is that as the dollars get shorter, there will be a disengagement from what we typically consider community engaged activities, right? So often budgets include the direct cost to run the study, right? So whether that be a vaccine study, whether that be a prevention study, and then there's typically a budget that is the stuff to engage communities to get them into the studies. When money is tight, the community engagement dollars disappear first. Like, let's be clear, because it, quote unquote, doesn't impact the science. And I use quotations around that because we know the impact on the science when you aren't engaging community. You won't see Black and brown folks in those studies because you haven't done the legwork to engage and be embedded in those communities to rebuild that trust that historically is absent, right? And so what we will see is a ripple effect. But the first thing that will go, to be clear, will be the dollars allocated to doing, community events, to host events in this community, to do stuff educationally here. All of those things will go first because they, quote unquote, are not the scientific budget. That's according to Dr. Darren Whitfield. I'm going to let my colleagues answer more now.
Tried to wait until my laugh paused. Dr. Burley, did you want to take it down?
Well, Dr. Whitfield hit the nail on the head. He said more than probably I would have said. And I'm glad he did. As someone who's most of my work with the HPTN happens within the external relations component of the network, and you can guess what external relations means. Everything that Darren lifted up. Clinical trials are only as effective as the people who are willing to participate in them. And you have to have resources to engage folks in that way. And when the funding was decreased, the partnerships with community-based organizations went away. The sponsorships of organizations, but also communities with diverse identities went away. And the ability to engage people in their places of worship went away. And so he's right. Those are things that get sacrificed first. And I can tell you that it's not an intentional sacrifice, at least from my perspective. It's just by way of how the dollars have been earmarked and allocated. But communities lose first. And if we expand that conversation to a global conversation where, most of the HVTN's clinical trials happen in places like sub-Saharan Africa. I can't even begin to tell you the consequences of studies that have just ceased to operate, and the enrolled participants who relied on those studies for healthcare, for all manners of other wraparound services, are no longer receiving them as a result. And what the consequences are for people in those contexts, whose lived realities look much different from ours here in the West, are important as well. That becomes out of sight, out of mind, for us, but is very present. This current government is very pro-US. And so, essentially for the HPTN, it was, you could continue to do your studies, but they have to all be moved to the US. And that means that the data that we receive won't be as accurate and complete as it should be, because as Danielle mentioned earlier, the brunt of the HIV epidemic is housed by women and girls in places other than the United States, but also our colleagues who were running these studies in other parts of the world, whose lives have been upended as well as a result of the funding consequences. And so communities lose first. What that loss looks like is different based on the context. And I'm sad to say that it looks much different in places like sub-Saharan Africa than it does in Seattle, Washington, for example.
Hmm. Okay, well, I'm going to add one more piece to this as we move to Dr. Campbell, which is, given all of this with the destructuring, defunding, et cetera, why don't we hear about this, right? Those of us who are working within the research space, uh, the NIH, the federally funded networks, many of us are aware, not all of us, but what about folks outside of the space that we work in? Obviously, this conversation is purposeful in raising this discussion and highlighting pieces of it. But what more should we be doing, and why is this not more of a conversation or discussion across the communities?
I think you make a really great point, and I think it also points to our opportunities to partner across our silos. We talk about that all the time in the research sphere, which is why you see implementation science start to penetrate in otherwise hardcore clinical research networks. This movement of implementation science into these division of AIDS funded networks was quite different than when we tried to usher in behavioral and social sciences. We were met with tons and tons of resistance, particularly in specific networks that are, again, focused on the more hard science research questions. But these sorts of things come from the top down. It's no coincidence that new federal leaders in positions of power who are implementation sciences can now push an agenda that then what do you call it, penetrates all of the research agendas of these networks that have remained taught for generations of scientific research. So it's new, right? But it's partly our responsibilities as advocates on the ground, as Black focused and Black led and Black concerned people, to continue to partner across silos and work together to develop strategies to disseminate this information out to our communities. So I fully expect subsequent conversations to follow this one. And I'm grateful to United We Rise for kicking off the initial, conversation, but I fully expect You Be the Cure and United We Rise and Prepping Black America and the Black Caucus and other Black-led, Black-focused, Black-concerned entities to pick this conversation and take it back out to the masses. But it's quite different to have this conversation in our community. We're already combating the stigma of HIV, combating the stigma of research participation, and justifiably so, and how we intersect with those traumas and how our very lived experiences are intersectional in their own right. So for us, I think it's us going back to the bases. We are a people who organize and we do it well. So it'll take for us to come back and organize these conversations very strategically in our community to do our due diligence to continue this message. Because, like Dr. Burley mentioned, this is not going to flip a switch in 3 years when this administration, knock on wood, changes, right? Because I've been hearing some rumblings about folks attempting to set aside the amendment that says you're a two-term limit. But we have a responsibility to work in real time to preserve the gains. It took us more than 40 years to get here. Yes, it's a very critical and pivotal moment, but we have to preserve the gains. It's only going to get harder from here.
Awesome. Wow.
If I
Thank
could,
you.
if I could just add to that to say that I think one of the challenges for our people in our communities is that folks are faced with so many layers of marginalization that, I have people in my church who have lost their SNAP benefits and are trying to figure out where their next meal is going to come from. And other folks who are trying to figure out how they're going to pay for their medication. And when that is your daily reality, then the realities around the consequences and the impact to research and development and community engagement become issue 12 of concerns on my list. And so I think it's really difficult for us as both community, but also the warriors, if you will, that have been lifted up by community to lead community in this way to continue to sound the alarm of these consequences in our sphere of influence, while also being mindful that most folks are just trying to figure out tonight, how am I going to eat tonight? Where am I going to sleep tonight? And it's really difficult to then generate that collective energy around these issues, when the issues that people are faced with on a daily basis are so much more present and prominent. And so, I think that's the benefit of all of us, who I know are kind of the both and, right? Like we're working on the solutions to our own problems, right? And because of that, we also understand the layers that come with multiple marginalized identities, and how we have to prioritize those layers for everyday folks to be able to even consider the impact of, cuts to, historical research networks around HIV.
Mhm. Wow. So, Dr. Burley, and Dr. Whitfield and Campbell, in the last couple of points that you all have mentioned, you've talked a little bit about um, some of the work of this cutting edge research that is focused on the lived experiences and the lives of Black people in Black communities, plural, because we know that we're not all monolithic, and and there are differences in what people do and how we live and things like that from one part of the country to the other. So when we talk about engaging with Black communities, uh, it's not just one strategy. Um, and Dr. Burley, you made a reference to SNAP and some other things. So it sounds to me like a lot of what we're talking about, and there's this term that I've been hearing a lot of called um, social determinants of health and political determinants of health. Um, how do you propose we work with, I mean, obviously, feeding my family, not to say that feeding my family might be more important to me than getting an HIV test, but when it comes to trying to figure out how to feed my children, it changes a whole bunch of priorities. Um, so how do we continue to try to conduct clinical trials that then lead to social services or medical services that are focused on our communities, given these determinants of health?
Well, one of the things I would say is I think we have to and this, I the funding nature from the federal government, I think, is devastating and also an opportunity. I think we have to think about how do we diversify what funding looks like and where it comes from and who are our partners. I am so glad we are in an era where something like 096 can exist because I never thought we'd be in a place where the HIV Prevention Trial Network would fund something that is so far outside of, right, its standard clinical trial. But I think the work that had to be done to get this study was so immense. And we should think about these opportunities and reshaping where things are funded and who we partner with, right? I was, the NASM conference over the summer, and there were folks who convened for the HISTORI Congress. And one of the things we're talking about at that meeting was how do we think more like business? And how do we start to reposition research in a way where we are enticing to, thinking from capital and thinking from, investment dollars in a way that people are like, oh, let's throw a few $1 million at this because we can see the potential of something that is marketable in the future. And I don't think we do enough of that work. I also think that our strongest ally as Black folks has always been community. But we have unfortunately fallen victim to where community-based organization and research don't speak or live in the same place. And when they have, that relationship hasn't always gone well, right? We all know the stories of agencies who partner with researchers and it didn't end well, right? But that we know that community is so important and has been vital to the success of Black folks. And so how do we reimagine, and I think Dr. Campbell alluded to Prepping Black America. One of the things that that document highlights is our need to redefine our relationship between researchers and community. And that I think that's where we get to the cutting edge stuff. There is so much rich talent, so much rich innovation that happens at community-based organizations, but researchers aren't there. They're not touching that. And how do we start to touch that and start to quantify, right? One of the things I learned in my PhD program is if it's not quantified, it doesn't exist, right? If there is no data, it's not real. And that's the world of research. If there is no data, it does not exist. So how do we start to work with these community-based organizations to use that data to really elevate what needs to happen, to demonstrate the need, but also demonstrate the capacity to conduct that type of research in communities, and then think about who are our partners in this research. Who are the investment firms that we go to? Who are the pharmaceutical companies? Because I'm not quite sure that we will ever see the investment. I'm optimistic that we may one day, but I'm not sure that we're ever going to see the investment from the federal government that we are accustomed to given this new reality. And so I think cutting edge research needs to be thought of differently and who we are working with to achieve those goals.
Yes, yes, I can see that, especially the value of and focusing on communities. Um, I'm just noting the time. We've got about 20 minutes left. So we still have some time and space for a couple of questions. I did want to note to folks who are viewing and participating in that regard that if you have any questions for our speakers, please just go ahead and drop them in the chat, and we'll highlight that for them and give them an opportunity to respond directly to questions from community folk. That being said, um, when we think, and each one of you in some way inferred that Black leadership at levels within the networks and DAIDS and NIH is non-existent, right? And maybe because it's non-existent, or because there seem to be so many challenges to completing one's doctorate or medical degree, and then finding ways to come uh, into your research networks and get involved in a trial and some of those other things. Um, what would you say that Black researchers and communities might be able to do to resist erasure while we continue to push the science forward?
So I want to pay homage to the Black researchers who did break through. They might not have made it to the top, but they got pretty close. Wakefield was the third person brought on by the HVTN 25 years ago when the network organized. And Wakefield was the person who introduced me to the HPTN. And oh, you're a young immunologist. You from the South, you speak the language. He would create opportunities for me to go and translate the science, if you will, for our communities. And my being a principal investigator with the HPTN today is a direct result of a Black leader within a network pulling in another young Black researcher and then maintaining that continuity within the network. And so, the late great Dr. Stephon Wallace followed Wakefield, and his whole team was Black. Now Louis Shackelford is in that role. His entire team is Black, and so I think that's the responsibility of those of us who make it to the other side of the door, if you will. That we have to continue. We got to prop the door open. We got to leave it open, and maybe even tear the door down. Um, and um, and sometimes that's easier said than done. But I think it's incumbent upon all of us to continue to feed that pipeline where we have that agency to do so. And so my entire team, I mentioned, is all but one person are Black, and the one person who isn't Black is Latinx. And so, nothing about us without us, I think has to be at the root of everything that we do, even when it comes at a tremendous sacrifice for ourselves.
Okay. Well,
Yeah,
thank you.
and in that spirit, because I think you're so right, Ulysses. I mean, I think we also have to think about, those pioneers, Cornelius Baker, right? And the work that he did not only for the HPTN, but the VTN, the ACTG, right? That there have been pioneers who may not have been leadership of a network, but made sure that we were at the table. I mean, there have been truly, right? Leo Wilton, Daryl Willer, Sheldon Fields, LaRon Nelson, Tonya Petit have all been Black folks who have led network studies. And so, to be clear, no one has been leading the network, but have made their impact in a way that have led the way for those of us who are now sitting, on this panel to be here. And so, I think it's important that we remember those folks and their legacies and the living legacies that exist because, I think we'd be remiss if we didn't learn the lessons and look at those folks and the work they've done to help get us to where we are right now.
Yes, yes. Thank you for speaking some of those names into the room. That was really important. Dr. Danielle?
Bring
I saw you
into
can
the
also
space
use.
Dr. Ada Mora and her work specifically within the HIV Prevention Trials Network and all of the, scientific advances that she was able to make as a part of that work. She's part of the reason why I am currently a sitting member of the HHS Adult HIV Treatment Guidelines Panel. It's again amplifying the work of those whose shoulders we stand on, be able to present before you all today as co-experts in this work. These folks reminded me, one, I'm in the room that I'm supposed to be in. Two, take full advantage of every single opportunity. And three, remember Sankofa. Turn around and bring those of us with you.
Absolutely. So open the door, bring folks along with you. Look, reach back, grab somebody's hand, bring them along, which happened. I know for me, there were folks who held the door and ensured that I had opportunities, both for leadership on studies and protocols and other places and spaces within some of the network roles. Um, so we're right about at the point where we're going to deal or address some closing questions. I don't see that there's anything that's coming to the chat, but I did want to go ahead and give you all this question, and then after that we'll go ahead and to get closing statements from each one of you. But the really kind of important question is um, is about the creating the space or opening the door, right? Those of us who are doing this work at some point, we may retire. I know it sounds crazy, but uh, we may move on to doing other things, or yeah. And so as we step back or transition to other aspects of life, there's a world of HIV researchers that exists that when we step out of it, it's going to create some gaps. So my question for you is what do you think would be important for the next generation of HIV researchers, the folks who are in pipeline, the folks who are in programs, the folks who are working on protocols and working in places or spaces within networks? Um, what would you like that world for them to look like that they would inherit? And if so, what can we do or what do we need to do today to move things in that direction?
That's a really great question. So, as someone who just has a pinky toe outside of that pipeline. I defended my dissertation on August the 22nd, 2005, and my degree was conferred like a few weeks ago. So it's still sort of really new. You know, the ink on the paper isn't quite dry yet. But again, I think I speak from two perspectives, right? One, as someone who is not quite out of the pipeline, but on her way out. And I could tell you that the prospects are bleak. The programs that were meant to create space for diverse voices and new voices in this work have disappeared. Our allies have held tight to that funding to preserve their peripheral existence, and their current mentees and other mentees who provide infrastructure to these clinical research networks, all of that funding is being redirected toward those individuals and away from the training programs that would have otherwise supported diversity in these research networks. That's one. So your FAST programs that create an opportunity for Black and diverse faculty, your T32 slots that give us secure funding for 2 to 3 years so that we can safely train and develop our research perspectives. Those things are gone. Our mentors who could have wrapped arms around us to give us a space to land, research projects are being canceled. So where do we go? Where do we go? We come right back to spaces just like this for rejuvenation, for the reminders of the messages that were put on the call today. Take it back to basics. Who's got us? Always us. And we have to remember that as we continue to lock arms around each other and chart a way through this mess. If not, what's on the other side for us is not going to be good if we're going to get to the end of this HIV epidemic.
Dr. Burley?
Yeah, Kristen, I think I heard in your question, you're asking us to maybe dream a little bit.
Absolutely.
And, I hope that future researchers would have carte blanche where, you know, they have the resources that they need to solve the problems that we all generally have solutions for. We just don't have the tools to execute the solutions, right? I think about Wakanda, if I can dream really big. I think the future looks like Wakanda, where we are the smartest in the room and we know it, right? I think those two statements have to go together because oftentimes we've always been the innovators. Our thoughts, our dreams were just stolen from us because we didn't have agency, and then we were made to believe that we weren't the innovators and the dreamers. And so I think it looks a lot like that. I think it looks like 096 that Dr. Whitfield has been lifting up, where research is truly integrative, is truly intersectional, and we see implementation science at its best, where clinical and community and scientific are all equals. I also echo what Dr. Campbell mentioned, and I heard these themes of mutual aid, but from our own communities. Um, my something my wife always says, and we debate about it. She says that um, integration, as it was executed, was the worst thing that happened to Black people. um, because she said when we were separate and unequal, we had more agency. We had our own stuff. We patroned our own stuff. We educated our own people. We trained our own people in the healthcare. And we were just dying to be over there with them. And if it had been done correctly, maybe it would have been fine. But we integrated it. It ended up being, together but unequal, right? And so I'm thinking in the spirit of that maybe this does create a moment for us to all get back into our rooms and to share mutual aid and to say, listen, we have the knowledge, we have the capacity, we just need probably more resources. So let's put it all together and see what we can get out of this. And I think a part of that is more um, institutions in rural communities, so
Mm-hmm.
that more Black and brown people have access to the health sciences and the health careers, to be the future researchers of tomorrow. I think, our uh, prominent Black folks who have resources, we started to see increased investments in HBCUs and things of that nature, which I think is really great. But everybody's not going to go to college, right? And so we need to have different ways of looking of imagining training and education for people in our communities. I think we over intellectualize research sometimes. And we've got folks in communities who know how to get people in treatment, who don't have educations, beyond high school. But they do implementation science better than scientists do because they know their communities. Imagine if we gave them the agency to be able to author on papers and to be able to learn about metrics, quantifying the outcomes that they've been a part of. And so I think it's this kind of this collective um, um, collective action that we have to take as people of color, as marginalized communities, as people of diverse identities, and kind of go back to our force of position in this country where all we had was each other, and we made the most out of it.
So back to the bases. Okay. Well, Dr. Whitfield, if you would
Yeah,
share with us.
I want to live in the dream world of my colleagues. And I would add to that, I envision a place where we are not only leading the tables, but we also, when we speak, we're listened to and our value is acknowledged without question. And I think we all know what that means, right? And so for me, it is really understanding the worth of Black and brown folks, understanding our knowledge is powerful, and that the things that we do well are of value, and the skills we possess are what's needed to change this epidemic. So for me, that's the thing I think about most is a world where we aren't questioned every time we raise a point or, people sort of want to second guess or have 3, 4, 5, 6 questions when they don't question our colleagues who have the same degrees as we do, who's sitting in the same rooms. So, for me, I think of those things. And I think in order for us to get there, we have to continue to show up and demand what we um are have earned and what we deserve, right? So I was on a call recently and it was discussed that at a recent meeting, the head of the HIV Prevention Trial Network said that over the life of this network, 63% of all participants in network study were Black. 63%. So you telling me this is a network of Blackness, right? So what does that mean to then acknowledge that in a meaningful way? And how do we start to ask questions of the folks who are currently in leadership around, so what are you doing for us? And what should you be doing for us, knowing that we will never end this global pandemic without us? So those are the things I think we need to do.
Wow. Well, I'd like to, number one, on behalf of United We Rise, I would like to thank all three of you for your time, your participation, for the wisdom that you have shared with us all, and the inspiration. I know I feel really inspired from spending some time with the three of you. Um, I know that my colleague Gary Daffin, you see him showing up in the bottom of your screen. Gary's gonna wrap things up and close us out and give us some tips for where we go next. Gary?
Thank you, Christopher. And thank you, Dr. Whitfield, Dr. Burley, Dr. Campbell. Good to see you all. And I know, Mac, we have participated in all three networks, and it was very helpful to the organization, very educational to us, the staff, and it really does help explain HIV and get more messaging out into the community for them to understand, why it's so important that we have research, that they participate, and that, the way to end this epidemic is through the community. So really thank you for your sharing with us and for all the work that you do. And thank you everybody for joining us. You can keep in touch with United We Rise, every Black body. You can find us there on all the different socials except for Facebook. Old school, we're just United We Rise on Facebook. So our next couch conversation will be on December 2nd at the same time. Keep an eye out for that. Please join us then. And until then, have a good fall and a happy Thanksgiving, which is only a few weeks away. And have a good rest of your day. Thanks.